Okay, well, good morning again. On behalf of the California HIV/AIDS Policy Research Centers and the UCLA Center for HIV Identification, Prevention, and Treatment Services, I want to welcome you back to day 2 of our EHE regional meeting, Taking Strategic Action to Address Substance Use in California. I'm Ian Holloway, the academic principal investigator of the Southern California HIV/AIDS Policy Research Center. And I want to invite you to take a moment to introduce yourselves in the chat by sharing your name, affiliation, and a few words about what brought you to this meeting. Our work together comes at a crucial time for addressing HIV syndemics among people who use drugs. Many of you have seen this paper from the Journal of Infectious Diseases that documents public health response to outbreaks of HIV among people who inject drugs across the US. Opioids, including fentanyl and methamphetamine, were present across outbreaks, and homelessness or unstable housing, previous incarceration, and hepatitis C virus exposure were common factors as well. California was not one of the states where these outbreaks occurred, but it's worth noting that all outbreaks happened in metropolitan areas, including some with substantial harm reduction programs and health services tailored for people who inject drugs. Last week, we had a series of panels and small group discussions to orient us to current epidemiological trends in substance use in California, evidence-based substance use interventions, and harm reduction programs and policies designed to address substance use in our state. Today, we turn our focus to understanding the implementation of these strategies to address substance use, and we'll engage in action planning to move these strategies forward across California. Our meeting today is structured around 4 key topics: opioid use, methamphetamine and other stimulant use, overdose prevention, and harm reduction. During the first half of our meeting, we'll hear from a panel of experts on these topics, followed by live question and answer. During the second half of our meeting, our breakout groups from day 1 will reconvene to engage in action planning, and Dr. Shoptaw from UCLA CHIPS will close out the meeting and outline next steps for our work. My apologies for the barking dogs. As we kick off the meeting, I want to remind everyone of key technical assistance resources that are available to us. I also want to highlight our upcoming meeting on November 18th, titled Advancing Efforts to Address HIV, HCV, and STDs in the Era of COVID-19 and Beyond, where we hope to continue these important conversations. To learn more about our upcoming meeting, we invite you to stay connected via our CHPRC website. I also encourage you to follow us on social media to find out more about our efforts to produce timely and rigorous policy research to address HIV and related syndemics in California. And with that, I'd like to thank you again for joining us, and I'll turn it over to our moderator, CHIPS EHE coordinator, Elena Rosenberg-Carlson, to introduce our first presenters.
Thanks so much, Ian. Good morning, everyone, and thank you for joining us today. Before we move into our strategies and action panel, I just want to note that you're welcome to share any questions and comments that you have in the chat at any time throughout today's session. And we will have a live Q&A discussion at the end of the panel. If you'd like to submit any questions specifically for the live Q&A, please submit them directly to Craig Pulsifer. Craig Pulsifer will be managing the live Q&A. I also just wanted to mention that we are recording today's session, and the recording and meeting materials from both meeting sessions will be posted on the CHIPS website within the next week. Today, our expert panelists will be sharing stories from the field about their work to implement evidence-based strategies to address substance use. We'll begin with Dr. Ricky Blumenthal, who's the Associate Dean for Social Justice and a Professor of Preventative Medicine at the USC Keck School of Medicine. Dr. Blumenthal, unfortunately, will have to hop off the meeting before the panel Q&A discussion, so we will try to take a few questions directly after his presentation. Welcome, Dr. Blumenthal.
Good morning, everyone. Happy to be here. I got caught by the mute button. I think by now I would be better at this. Anyway, great to see many of you and recognize names I've known over the decades. So I was asked to just give an overview of strategies for preventing overdose. So I'll just start with, I have no disclosures to, conflicts to disclose. Talk a little briefly just about the growing overdose mortality crisis that we've all been living with the last 10 years or so. Then talk about the prevention strategies in some details, and then conclude with some remarks about implementation challenges. I just want to say, seeing some of the names on there, there are plenty of people on here who are more expert at some of this stuff than I am. So sorry I'll miss the discussion, but I'm sure that they'll correct the errors that I have. All right, so we all know that after what appeared to be a small dip in overdose mortality, it's gone up again. We also know there are regional differences, although the recent report by Chelsea Stover and our own research that Alex Kroll and I have conducted indicate that fentanyl is now prevalent in the West and will no doubt be contributing to greater overdose mortality here as it has done elsewhere in the country. The COVID pandemic has made a lot of these trends worse. So greater isolation, some restriction in the availability of services has appeared to be leading in a relatively linear fashion to increased overdose deaths over time at a national level. And in California, this data is a little old. We've seen at least a 23% increase in overdose deaths. There was recent reporting in San Francisco that they've had a real substantial, I think it was doubling of overdose deaths this calendar year. So things are getting worse. There are things that we can do about this. And before I get into the details of the different strategies, I want to make the point that for the most part, people who use drugs have really stepped up to this threat and have been instrumental in responding to the potential loss of life by both participating in overdose education programs, receiving naloxone, and coming back for refills. So in my view, one of the first frontline responses is, of course, this training to people in my world who inject drugs, but in general, people who use drugs, rescue breathing or CPR, receiving naloxone, and then calling 911, of course. In California, most of the distribution happens through a couple of sources. So syringe service programs, of which we have, I think, nearly 50 now, pharmacy sales, and then prescribing primarily out of emergency departments, addiction medicine services, and primary care. The great thing about this approach is it has high acceptability among the population for who it is targeted, and people use it as intended. Another strategy is drug checking, and drug checking has been around globally for a long time. Most of it in the early years was used at festivals where people could test the drug to make sure, for instance, that the ecstasy is actually ecstasy and not speed, for instance, or an opiate. There's increasing distribution of fentanyl test strips, and I'll show some data both from San Francisco and then talk about some data from Los Angeles about that. And then a few places you have these mass spectrometer machines that are able to tell you precisely what's in a sample of drugs. The places that I'm aware of that have that are Vancouver, Rhode Island, and Chicago. The fentanyl test strips at the moment appear to be popular, although they're relatively expensive. So each one costs about $1, and there can be some challenges using them. But when people do use them, there's good emerging data that suggests that folks respond in ways that we would hope. So they do tester shots or use smaller doses or inject more slowly to make sure that they don't overdose if fentanyl is present in the drug. Now, the next two things I'm going to talk, well, actually not the next two things. The next thing, obviously, is these safer consumption sites. There are places where people can go to use drugs that were illicitly obtained. They provide sterile supplies in a clean location. And then they have these cool down rooms where people are observed after using, so that if there's a problem, there's a response. The good news is there are hundreds of these, probably almost 200 now, because Canada, in various configurations, has widely adopted these programs to respond to their overdose crisis. But you have the advantage of immediate response to overdose. There's no one has ever died who's used drugs in one of these facilities. And you get these other benefits. So it's a clean place, they're clean supplies, so you get lower rates in general of HIV and hepatitis C transmission, and people aren't sharing material, so you don't get that sort of injection-related transmission risk. And then you probably also get improvements in abscesses and effective endocarditis because people are using in settings that are have better hygiene. So the other thing is safer supply, and I sort of think about this two ways. Obviously there's heroin-assisted treatment. This has been well reviewed. It really does work, and where it has been available, the results have been stunning. So obviously reductions in injection-related risk, improvements in educational outcomes, improvements in employment outcomes. Anecdotal reports from participants in programs, use terms as like, I can now begin planning for the future. So I think these would be highly acceptable. The bigger problem, and this is a problem with all of these strategies, is sort of those of us who don't use drugs and what are we willing to make available to folks who do. And then the last is the deregulation of medication treatments. The COVID, maybe the only positive thing that's come out of the COVID-19 pandemic has been a loosening of regulations around these programs. And I know in Northern California, physicians and others have done a terrific job of making buprenorphine widely available to people who use drugs. We're a little slower in LA, but the COVID-19 has really created an opportunity. And I know my colleague, Rebecca Trotsky-Sur, who's a physician at LAC USC, in the last couple of months has been able to start 250 people and her crew, 250 people on buprenorphine, due to the relaxed regulations that make it easier for people to start. But implementation strategies remain. There are obviously these regional differences. This is from an MMWR from a project that Barrett London leads. And the key thing to look at here is sort of what's the ratio of number of naloxone, people receiving naloxone per death, and number of doses. And in the West, we're doing really almost better than everybody else in terms of getting that out there. So that we've done well there, although there's more that could be done. This is just data from studies that Alex Kroll and I have conducted. And the key take home here for me is that when we began really increasing naloxone distribution, people who inject drugs began using it and then using it to reverse overdoses. So this was sort of third column group, and this one here show those changes over time between 2013 and 2018 with rapid increases, even in the context of more overdoses, in both witness use and then appropriate response to naloxone. So the people who use drugs are doing their job. A lot of the other things are, are sort of dependent on us stepping up to the plate. This is recent data from Dr. Kroll in San Francisco from 2018-19 on the fentanyl test strips. So about half of the people in that sample had used them. About a quarter had used them the last 30 days. It looks like the distribution is there are a group of people who use them a lot, and then folks who use them less. And then fentanyl is widely present in the drug market in San Francisco. I think that's true also in Los Angeles. All right, so the safe consumption sites are under consideration in several cities. We had the federal trial for the Philly experiment that, theoretically, if we have a change in regime in the next 3 or 4 months, there may be some loosening of this and a chance for people to begin to initiate this. We had legislation in California that passed a year ago and then was vetoed, and then this year they pulled it. But I anticipate that we'll have legal authority to move forward, again, depending on the results of the election. We probably should be talking more about both deregulating medication treatments and then also implementing these sort of heroin-assisted treatment approaches, given their evidence base. So this is just data from San Francisco and Los Angeles that Alex and I collected. And this is just to make the point that the orange one is sort of the more recent data. The people who use drugs are playing their role. They're enrolling these programs, they're receiving naloxone, they're using it as appropriate. We are failing, right? We don't have safe consumption sites not because drug users don't want them. We don't have them because people who don't use drugs don't want them. And similarly with the safe supply approaches, and we desperately need them. We're not gonna. There's no easy solution to fentanyl use in terms of its danger for overdose death, unless we take the next couple of steps. So we truly deregulate medication, we contemplate and implement heroin-assisted programs, we widely implement safe consumption sites. So those are our remarks. I think at the end of the day, it's really going to be on the rest of us to step up to this challenge to preserve the life and well-being of people who use drugs. Thank you very much.
Great. Thank you so much, Dr. Blumenthal. We did receive just a couple of questions that I'm hoping we can maybe talk a little bit about now before you have to hop off the line. So the first question was, is there data on HIV incidence among people who use meth versus people who inject drugs, appreciating the overlap of people who slam?
Well, in my studies, so the studies that Alex and I have done in San Francisco and Los Angeles in the last decade, the people who are mostly infected are sexual minority men who use meth. So I think they're at the highest risk for HIV in my studies, and I think the rest of the literature supports that.
Thank you. And then we also received this question. Do you think our naloxone success in the West will go down as fentanyl becomes more popular in the opioid supply networks?
Well, it's interesting. Alex and I have had these email exchanges the last couple of days that are a little terse about this topic. So, I think naloxone, giving out naloxone always makes sense. It always makes sense. The epidemiology of overdose mortality is complex. So if you think about the causal chain of a death, naloxone can help reverse that. And I actually discovered in our own data, looking at the 2018 data, we actually, and I'll sort of scoop myself, and I haven't looked very carefully at that, but it looked like what we were seeing was that people were using multiple doses of naloxone pretty consistently, and that's because of fentanyl. So in some ways, I think the issue is we probably need to do even more naloxone distribution, think about higher dosing levels, in recognition that fentanyl is now the predominant opiate that people are using. So I think we have to respond. So does that mean that if we do that there will be fewer fentanyl overdose deaths? Yeah, there will be. Will it mean there will be none? No. And that's because of the other factors. When people use alone, if people are using in single occupancy only hotels, if people are new, there are all these other things if they're using other drugs on board. So it's complex. So I think the wrong response would be to see increased fentanyl deaths as somehow an indication that naloxone distribution doesn't work, because I think it does. And if we took it away, we'd see triple and quadruple the number of overdose deaths than we do now.
Wonderful. Well, thank you so much, Dr. Blumenthal. Now we'll move on to our next panelist, who is Wayne Rafus, who is the Prop for All coordinator at the San Francisco AIDS Foundation. Good morning, Wayne.
Good morning. Let me share my screen. Great. My name is Wayne Rafus. I'm the Prop for All coordinator at the San Francisco AIDS Foundation. PROP stands for Positive Reinforcement Opportunity Project. The San Francisco AIDS Foundation began implementing contingency management in 2010 to male identified participants, gay, bi, and trans men. In November of 2019, the program was expanded to the 6th Street Harm Reduction Center to begin to provide services to folks who are experiencing homelessness, at risk for overdose, at risk for HIV. Many of our clients have strained family relationships, experience unemployment, and have ailing mental and physical health due to stigma and issues with access to traditional medical facilities. So I know that you all received an overview of contingency management, so I'm just going to go through that really quickly, define what it is. Contingency management is a behavioral therapy that uses motivational incentives, tangible incentives to help a person become abstinence from drugs and alcohol, to encourage sobriety and behaviors that support healthy living. Clients receive incentives when they obtain their substance use goals and make lifestyle changes within their daily lives. Examples of that include drug-free urine specimens, which have shown to increase retention into treatment and attendance. So we know that drugs and alcohol make people feel good, and drugs and alcohol are powerful when life is not rewarding. If you don't have a life with a bunch of rewards, if you're experiencing poverty, unemployment, family conflict, or depression, people use those drugs to escape from those realities. Feeling good acts like a reward that makes people use drug and alcohol more. So in this context, we're going to talk about contingency management can be used for stimulant use disorders. We provide tangible reinforcers for demonstrated drug abstinence. And so we monitor targeted behavior by having folks come in 3 times a week. They test their urine. At the 6th Street Harm Reduction Center, it is not mandatory when folks come in. If they want to test their urine, it's really opt-in or opt-out. Prior to the pandemic and the shelter in place, we had a lounge for folks to come in because there's not a lot of places in San Francisco for folks to get off their feet or to get rest if they're experiencing homelessness. Many of my clients tell me they're literally on their feet all day long and walking. And of course, when we think about folks pursuing their goals, they really have to have their basic needs met. That's food, shelter, and having folks that they can talk to that really understand them and won't judge them, that will lead with love and compassion. So these are the steps. We provide incentives when targeted goals occur. The longer period of abstinence equals a larger incentives. Clients do not receive incentives when the behavior doesn't occur. And contingency management is the most effective non-pharmacological treatment for initiating abstinence. Some of the awards for contingency management, I think a lot of folks will focus on the incentives, and our incentives is really based on what the client wants. A lot of our clients are right now requesting gift cards to increase their ability to get food. And some of our clients are also requesting like a MasterCard or a Visa gift card to help pay bills, or even secure housing for the night, because a lot of our folks are still street homeless. And so what we're trying to do is really teach new behaviors when we're asking people to show up on time when services are delivered. We promote relationships and connections between those giving and receiving incentives. And many of our clients have been traumatized attempting to access services or stigmatized for their substance use. And a lot of that is really based on drug wars like Just Say No. And I think a lot of our clients would say that they are dehumanized in the community at large. Literally, people walk over them or step over them. And so they don't feel like there are spaces for them, safe spaces for them to access services. We promote a positive atmosphere and communication with our clients as person-first language. We promote self-esteem and self-confidence, and we help teach accountability. So now I'm going to focus a little bit more on implementation. Our implementation began in November 2019, like I said. And like I said, our clients are facing a myriad of issues while also attempting to work on their substance use goals. And many of our clients or at greater risk for overdose from contracting HIV, hepatitis C, and sexually transmitted infections. The contingency management interventions are based on principles of basic behavioral analysis, like I talked about. We are low barrier, low access. We engage our most vulnerable community members, like I said, who report problematic stimulant use, specifically meth and cocaine. The project works with injection and non-injection substance users. All of our clients have access to Narcan and health education to mitigate the aforementioned rise in overdose and sexually transmitted infections. I also like to say that this intervention could save the community money by linking people with needed services. We provide services to navigation centers to address homelessness, HIV counseling and testing, because a lot of our folks at times will do what they need to do to survive on the street. And some of that includes sex work. And we know that folks get more money when they do certain things. We have a hepatitis C elimination program that we refer our clients to, because we also understand that people are using, and sometimes they're using to get well. They might be on the run and not have a safe space to do that. And I think that really highlights the need for safe consumption spaces, places where our folks can have access to a clean and safe and sterile environment to use their substances. So I say our programs are low threshold. We are warm and welcoming. One of the things we do is, like I talked about, we really want to reduce stigma. I think stigma is one of the largest or the biggest causes of reasons why a lot of our folks don't come in for services, because they feel like they'll be judged. We also utilize a strength-based practice. It's a collaborative process between a person supported by services and those supporting them. And we really want to understand through client-centered counseling and motivational interviewing what's really going on with this person's life and what steps do they want to take to work on their substance use. We don't force anyone to do anything. And we don't come down hard on people if they deliver a urine sample that has their substance, has cocaine or methamphetamine in it, because we know that doing that is actually interrupts treatment, and it acts as a barrier to folks wanting to work on their substances. Okay, so there's no requirements to abstain. People complete drug screens and tests and not react for stimulus use or paid incentives. Folks who come in who are struggling are offered the opportunity to speak to staff, to talk about what's going on in their life, to address ambivalence, or maybe an abstinence goal is really not going to work for them depending on their current situation. So we talk to folks about that. Drop-in peer support is provided 3 times a week at the Harm Reduction Center. And I'll talk a little bit about COVID. I just wanted to give y'all a snapshot of what services were like before the pandemic. And clients have access to licensed clinical staff for more intensive counseling needs. A lot of our clients coming into our program, I think, are dealing with complex trauma. A lot of them are dealing with feelings and symptoms of depression. And a lot of them have been so disengaged from traditional services because of stigma that it's really impacted their self-esteem and their self-confidence to work on their goals. All clients have access to meter services, like I said before. And our next slide. So in March 2020, COVID-19 greatly impacted all of us and our ability to provide in-person services. And it was really challenging and problematic for this program specifically, because a lot of our clients don't have access to phones. And if they do have phones, the phones either gets lost or it gets stolen, or it might get traded for something that they need. And so I began to work with people who had phones 3 times a week. And as a program and as an organization, we started talking about how do we overcome this challenge? And one of the things we talked about was getting phones and distributing phones to people who were not being served, who were still experiencing homelessness. A lot of our folks didn't have access to PPE. They didn't have access to masks or gloves or hand sanitizer. And a lot of folks were not receiving accurate information to protect themselves from this pandemic. And I have to say, at the 6th Street Harm Reduction Center, leadership there immediately started providing PPE masks and gloves and hand sanitizers, and really kept their services running to really try to mitigate the impact of the overdose deaths that we see in the community right now. Okay, so we virtually successfully engaged 21 participants back into our program. And I have to say, a lot of this is really based on our folks, our clients, and they're really wanting to work on their substance use goals. We could say that's based on resilience, and we could also, that's based on folks wanting to survive this pandemic. So as of August 14, 2020, we began to see people again in person. It's available on Fridays from 5 to 6:30. For folks who don't have phones or access to technology, they can come and engage with me and other staff and get the services that they need. We are not doing urine testing right now because it poses some type of issue around safety for our staff. And so what we're doing is some really intensive counseling. I am happy to say that we are starting to give away urine testing kits now to a couple of our clients that really wanted to test their urine. And I have to say, around the urine testing, what I've observed is people build their confidence each time they come in and they give a negative urine test. They feel much more engaged in the process. They feel like they're working on their goals. It helps build their self-esteem. It helps build their self-confidence to work on their self-determined goals. And that's another area I think that I really like to put out there, is that, like I said, we don't force folks to do things. We really use motivational interviewing to address ambivalence and really to understand what the client wants in their life right now. We don't condone drug use, and we also don't condemn it. We accept that people can and will make good decisions for their lives when they're given the resources to do so. Implementation at the 6th Street Harm Reduction Center is a group and a team effort. The health educators down there talk about the program to clients coming in, getting access to Narcan, to clean syringes, and to wound care materials that they need if they have abscesses. Folks are provided referrals to medical staff that are caring and compassion and lead without judgment. And I think that is a big piece that really supports our clients and makes them feel like they're in a safe and brave space so that they can work on their issues. Lastly, I would say this program could really fit really well in a SIF. These services are really client-centered. The client is at the center of these programs and services. Like I said, we use person-first language. We attempt to address abstinence, but we're really trying to lift our clients up and to really build them up so that they can work on the issues that are most impacting them in their lives. So thank you for giving me this time. Afterwards, we'll have time to answer any questions that folks may have. One of the other things I want to talk about intervention before I end, though, is it's problematic. We found it's problematic for folks to consistently work on their goals when they have polysubstance use. And fentanyl has really impacted a lot of our folks negatively. And so what we're starting to do is we're working with programs that provide, of course, buprenorphine and access to medical assisted treatment to really start to help folks who want to work on their opiate use, because I found that the intervention is less effective if we're not doing that, because we would have people come in who were so sedated, and staff would be so concerned that a person may go out on us, that we would have a plan in place if an overdose would occur. So that's something that we're working on right now. We're building relationships with San Francisco General that has Project Houdini Link, which is a 6-month contingency management program that specifically works with people who want to change their relationships to opiates. So I just wanted to throw that out there. Like I said, we offer Narcan trainings. Whenever possible, we distribute that to as many people as needed. So that's my presentation. Thanks for having me. And I look forward to the question and answer portion of the conference.
Wonderful. Thank you so much, Wayne. Next, we'll hear from Dr. Andrew Herring, who's the principal investigator of the California ED Bridge Emergency Buprenorphine Treatment Project. Welcome, Dr. Herring.
Hello, everyone. So happy to be here. Let me just fire up a slide and we'll get started. You cannot share a screen while the other participant is sharing. Is that, here we go. We'll try it again. There we go. Perfect. Okay, great. So I am very, very honored and humbled to be here with such a collection of people doing real work on the ground, as well as high-level science to figure this all out. I'm an emergency physician. I also specialized in addiction medicine and pain medicine, so I've seen opioids in all kinds of different circumstances. I'm the PI of the California Bridge Project and involved in ED Innovation, which is an NIH trial of injectable buprenorphine in the ER. So I've got my hands in various pots. So today I wanted to talk about the California Bridge. I think the intro is just to really, we as a group need to collectively start talking about more openly every time, every conference, every lecture, that we are living in the end game dystopian failure of drug enforcement policy and abstinence-based drug treatment, which is hoovering up trillions, billions of dollars, and we need that money to do things that actually work. So we're in this bizarre situation where the things that actually work occupy this tiny fraction of the money and attention: harm reduction, naloxone, medication treatment, whereas the vast majority of money is spent on things that we know actually harm the population that we're trying to help. And I think that that's part of the spirit of the bridge, is this is not about eradicating opiate use disorder. It's about developing a cohort of physicians, nurses, techs, who are based at hospitals, who sincerely and authentically care about people who use drugs and are dedicated to deploy whatever resources are available to them to help them move away from harm and toward their own self-directed goals in life, whatever those might be. So the tip of the spear for us has been medication. So this is Danae Reed. She's a physician's assistant that I've been working with for years. And you can see that she's sitting in our fast track area. So the fast track is the area of the hospital, which is for low acuity. There's no monitoring, there's typically no labs, it's quick. So hospitals traditionally have been kind of these zombies that just sort of squat in the public health landscape. They take up a lot of money and resources and attention, but don't really contribute to public health, and have been, for very good reason, maligned for that. And so when people think about public health infrastructure development, they tend to think about everything but the hospital, and for very good reasons. So the bridge said, well, okay, let's at least try here. Let's assume that the lights are on and there are a very high-powered group of clinicians who are there 24/7, who could play a positive role if they were given the right training, equipment, culture, and direction to do so. So the fast track, which typically had been a place to fight about Norco prescriptions, first to give them out inappropriately, probably, and then to deny them in the setting of context. We said, well, why don't we make this a 24/7 low threshold buprenorphine access point? And when I say access point, this is not, we talk about inducing and we talk about starting, but really this is an opportunity to see if this medication has any self-interest to you. There's no strings attached. It might help you for 10 minutes. It might help you for a day. it might be the beginning of a year-long, a 10-year-long trajectory of treatment. We don't care. The thing that we are here to do is to give you a low threshold opportunity to bypass a lot of ridiculous baggage around intakes and qualifications and intent and commitment to treatment and all of this stuff that really doesn't help people, and just provide a chance to try it out on your own terms. Does this work for you? If it does, there's more where this came from. Hey, as long as we've got that fixed, why don't we move on? Let's talk about your housing. Let's talk about your goals for employment and all these other things. So here you can see she's got in her hand our algorithm, right? People will obsess about structure. What is the treatment algorithm? What is the inclusion criterion? What is the dosing? What is the timing? What do you do in case of adverse events? All of this stuff. I love doing that in research. In clinical practice, that's just been a huge barrier. So with the bridge, we said, no, we don't need a 3-page algorithm on how to start buprenorphine. This is an incredibly simple medication. What we need to do is make sure we understand what the patient wants. So our algorithm is basically, have you tried buprenorphine before? If yes, great. How much would you like right now? If they've never tried it before, we walk people through, what the drug does and how they might try and start it, and let them choose their dose. So these small changes are actually really huge in creating this culture of partnership and acknowledging reciprocity. It's okay that the physician and the hospital need to kind of prove their value. We're so used to saying, okay, this person who is using drugs needs to prove their value to me. They need to prove that they want to care. They need to prove they're committed. No, it's the opposite way around. We need to prove that we have value to them. We need to prove that we can help them. And that's what's really driven how we've tried to convert the zombie hospital staff into being an army of folks who are able to bring medication treatment to folks who are using opioids at 3 o'clock in the morning on Sunday or 2 o'clock in the afternoon on a Tuesday. So we've had 50 hospitals sign up for our first cohort. And now with the behavioral healthcare pilot program, we've had 209 hospitals apply to start. Now we'll see what they can really do. Are they going to be zombies with that money? Or are they actually going to do something? That's to be determined, and we're working hard to push it in the right direction. These are the signs that we have people put up. Again, are you struggling with pain pills or heroin? Should probably add fentanyl there. We can start you on buprenorphine today. We don't use euphemisms. We don't say, would you like help? Are you interested in recovery? Again, acknowledging that we are on the hook to try to prove that we can provide self-interest. And in that case, often in crisis, if you're homeless and you're in withdrawal and it's 3 a.m., this is not the time to talk about psychosocial cognitive behavioral therapy, long-term intervention. This is like, we can give you buprenorphine right now to take away your withdrawals and forestall them for the next days or however long you want it. So we encourage that these be put up in triage, in registration, and turn the entire volunteer staff, everybody, into a big mechanism to recruit people into the medical system that they very rationally have perceived as being overtly hostile to them for pretty much most of the time that we've had a medical system. So the overall, I could proudly say that this has really been an incredibly successful program. I think it was much more successful than people thought. You just don't think of the ER and the hospitals as being a place to do this. But in about 16 months or so of operation, we identified nearly 12,000 people with opioid use disorder. And the thing I'm most proud of, right, is that nearly 8,000 people actually got the drug into their mouth. I know that's an incredibly bioreductionist approach, but from a logistics standpoint, can you take a drug and get it into someone's mouth is a big deal. So I feel very proud that we weren't patting people on the back. We weren't diagnosing them and giving them a pamphlet. We got a bunch of people to learn what buprenorphine is and get it into people who needed it. With 5,000 people linked to a follow-up care. And this idea of linkage is also a bit absurd. Now, I think we all wish that there was a linearity to opioid use disorder. I find a person with opioid disorder, I diagnose them, I initiate treatment, they link to care, and then it just goes off into the great, happy future. It's not like that, right? It's a circulating population of people coming in and out of treatment based on this balance of survival needs and motivations and characteristics of the treatment they're receiving. So it's, linkage, I think, is very confusing. It's really about creating a relationship with a group of people. So we endeavor to make our emergency departments develop a longitudinal, authentic relationship with people who use drugs, and to do whatever they can to leverage that relationship to move people away from harm and toward their personal goals. So if someone is linked to treatment, quote unquote, for a day and then comes back the next day, that's great. We see return visits as a good thing. So you can just sort of see the general trends here. We started, basically, in 2016, it's Highland and God, maybe Davis a little bit, but basically no emergency departments are using buprenorphine in the entire state. And now we have thousands and thousands of people getting buprenorphine. So it's a radical change, which I hope will pave the way for a population scale impact. Imagine if every community knew that no matter what, they could walk into the ER and get buprenorphine, no question asked, and then get linked to harm reduction and wraparound care and all these kind of things. I think it really would be a game changer. Imagine if that is also integrate the EMS, like in Contra Costa County. We are the first county in California that now has buprenorphine on the ambulance. So literally you can call 911 when you're in withdrawal and get buprenorphine in your mouth, right? It's kind of mind blowing. So that's really happening. So we have 44 hospitals also treating inpatients. We have 45 hospitals that are doing buprenorphine directly after overdose. And this is just part of like breaking down a lot of pharmacologic baggage in the treatment world. It's kind of wonky or whatever, but there are these misguided ideas about how you can and can't use buprenorphine. And post-overdose is a perfect time to put buprenorphine into someone's mouth, and it works great. So we've got 45 hospitals doing that. And we're also really working with the OB population, where they often have more access to resources and social works, and they're just involved in that just horrific criminalization of mothers who use drugs. And we're really fighting against that with some good success, with some wonderful partners. 1,600 ex-waivered providers, right? And again, a zombie provider just doesn't really do us any good. So we're happy to see those providers getting their waivers and using them. We are incredibly proud of our naloxone distribution. We had to go to bat with the California Board of Pharmacy and all kinds of things, because if you can believe it, of all the places that you couldn't put naloxone in someone's hands, it was a hospital. So the librarian could give you a box of naloxone, but hospitals couldn't because they were all bound by pharmacy rules. So we had to go to the Board of Pharmacy and all these people and get that all clarified so that now we can just give you a box of naloxone, cover it like a NASCAR with all stickers on how to reach treatment, and give it to people without any unnecessary barriers. So that's meant that in the first year, we've given out over 6,000 boxes of naloxone. This means that the police, the highway patrol, the paramedics, the firefighters come to our ER and ask for naloxone that they can have and give out on their in their work. So it has turned the emergency department into a community hub for access to naloxone for providers and patients and family, as well as for buprenorphine. We have 37 hospitals that are beginning this EMS journey. I think that there's going to be a lot there. I mean, EMS is sort of a giant boondoggle. If you're aware, there's just a lot of crazy financing where you can't get a primary care doc, but you can get a $250,000 enormous machine with 3 people on it zooming through traffic to take care of your nosebleed. So the things that drive that, again, we're going to repurpose that to help people who use drugs. And the so far so good. There's a lot of pent up demand on the part of paramedics and EMS to do a better job. They hate this situation of just reversing people. They decline transport and they go off. It's talk about a burnout. So to integrate them into the chain of treatment is really, really wonderful for them as professionals. And so I actually think it's going to work really well and grow. So at Highland, we have a little bit of a unique system where myself, I have another physician who's also an ER doc and addiction boarded. We run the Bridge Clinic. So that's really kind of breaking down this mold of we're all born to be ER doctors, internists, outpatient doctors, psychiatrists, et cetera, which is just really silly, right? Is that these differences between setting and patients are completely arbitrary, and they really get in the way. So to create a truly seamless experience between the ER and the outpatient treatment, we created our own clinic. We now have internists and others involved in the care as well. It's anchored by substance use navigators. This is Zaire and Kelvin, and their goal is basically to be an advocate. They're not there to share lived experience. They are there to protect patients against the hostility and confusion of the system that we've set up. So their work is not primarily with the patient, it's with the system. It's because what I've seen is it's not that my patients need motivation. They're motivated. What they do is they need to figure out how not to absolutely freak out when the pharmacist is telling them they can't have their medication because their ID is like 2 days out of date. And just this trivialities that they encounter on a daily basis. That's there to smooth things out and to make things work. And to be true serum, I mean, how many clinics have told us that they've got a low threshold program, yet then Zaire comes back and tells me, oh yeah, they said they have a drop-in clinic, but drop-in means that you can talk to the clerk and be scheduled in 2 weeks after you've done 3 blood tests and 2 urine screenings and you've gone through insurance checks. That's not low threshold. So having a secret shopper kind of true serum for the system is essential. And that's been really, really helpful to use their knowledge to help us drive iterative improvement in the system. So I think with that, I'll just say that we're really effective in reaching people. Now, is this translating into long-term benefit? Is this translating into prevention of death? I don't know. I really hope it is. But by 2018, we're seeing 650 visits for buprenorphine just at Highland Hospital. By 2019, 2020, we're more up in the 800, 900 range. So we really do feel like people are coming to trust the emergency department for their needs there. The future is about injectables. This is clearly the way to go. This is under the trade name of Sublocade. Soon it will come out from a different company, Braeburn, Brixadi. But this early utilization of injectables in the patients in crisis, in the ER, on the ambulances is really how we're going to make an impact, particularly with fentanyl. And that's something that I'm really looking forward to seeing development on. So with that, I really thank you for your attention and happy to pass the baton.
Wonderful. Thank you so much, Dr. Herring. So our final panelist is Denise Lopez, who is the Harm Reduction Services Manager for the HIV Education and Prevention Project of Alameda County. Welcome, Denise.
Hi, thank you. And thanks everybody for having me here. I'm super excited. Dr. Herring, I think you have to stop sharing your screen. How you doing?
Okay, here we go. Sorry.
All right, that's okay.
Stop share.
All right, thank you. Let's see if I can share mine. And share screen. Oh, no, it doesn't want to work. Let's see. All right, there we go. Sorry about that. Thanks for the great introduction. And I am Denise Lopez, and the HIV Education and Prevention Project at Alameda County is very long. So we go by the acronym HEPPAC, which is way easier and just great to say. So I'd like to give you a little history on, wait a minute. There we go. What is
Sorry to
happening?
interrupt, Denise.
Yes.
If you want to click on from beginning up there in the upper left-hand corner where it says from beginning,
Yes.
there you go. Then you should be able to.
Uh-oh, yeah, that's not the beginning. Let's see. Okay, so what is HEPAC? Who are we? HEPAC is a harm reduction agency, the first of its kind in Oakland. Today, we are still committed to challenging stigmas and normalizing awareness in regards to our community and the folks that we serve. In July of 1992, almost 30 years ago, a group of community organizers, including AIDS activists, healthcare providers, and active and recovering drug users, united together to develop a needle exchange program known as ACE, Alameda County Exchange. It was in West Oakland, and they wanted to address the higher rate of HIV infections among IDUs. In 1994, HIV Education and Prevention Project at Alameda, also known as ACE, became a 501(c)(3) nonprofit. We have been operating as HEPAC ever since, providing syringe access services available to the Black and Brown communities throughout Alameda County and Contra Costa County. Needle exchange programs have long been underground and illegal, but HEPAC has fought hard and along paved the way by encouraging and convincing the lawmakers at Alameda County and Oakland, in particular, to making syringe service programs legal and providing standing orders. HEPAC is also a Black-led agency. We are one of the biggest harm reduction and syringe exchange programs in California. We're third from San Francisco and LA. So what is harm reduction? Harm reduction is working with people to reduce harm that can be caused by taking part in risky behaviors. We provide people with tools and support as well as education to empower folks to be safer in whatever choices one may make. We do this with respect, dignity, and care for our people. During this pandemic, we included the necessary PPE and opportunities for self-care that might otherwise not be available. So harm reduction during COVID. We've had to wear plastic face shields and masks, hand sanitizer, syringe access as needed. And when I say syringe access as needed, I'll give you an example, like in Contra Costa County, it used to be one-on-one. You know, you had to have a syringe to get a syringe. And now they have actually changed the law where it's needs-based. You can get as many as you need without having a syringe, and there's no problem. So we are very thankful for that. Condom distribution, assistance to Safer Ground hotels. And Safer Ground hotels, if folks don't know, those are the hotels in Oakland where people who are unhoused and haven't had anywhere to go, and they may have COVID symptoms, or really, I don't even think you have to have COVID symptoms now. You can just need a safe place to stay, and you can go to the hotels and live there. So they have 2 hotels in Oakland, 2 that we go to at least. One is for people who do have COVID, and the second one is for folks who are unhoused and may have COVID symptoms or nowhere to go. So HEPAC, we go there and we outreach there every other month. We used to go every week, but because we've been going there since this pandemic started, well, no, probably since about March, we've been going there. And we have met the needs of the people. We have taught them how to use Narcan. We have did safer injection classes, you know, how to inject yourself safely. We have gave out tons and tons of Narcan and fentanyl test strips. We actually leave a table of syringes and pamphlets and needles on the table at the hotel so that folks, if they want to come and get them, they can get them. So we don't have to go there as much. So now we go every other week to both hotels. Okay, smoke pipe distribution, which is actually awesome. This was just passed a couple of years ago in California to distribute pipes. It used to just be only syringes. And we were so happy at HEPAC to be able to provide this tool for people, because in our community, most people smoke, you know, they smoke out of pipes. A lot of people do inject drugs, but a lot of people smoke pipes. So if we're gonna pass out things that are safe, we need to be able to pass out all things that are safe. So we're very happy and proud about that. We have had to step up our outreach. We used to do mobile outreach 3 days a week, and now we're doing mobile outreach 4 days a week, working in small teams and making sure that we cover all of Oakland, Contra Costa County, Richmond, Bay Point, Antioch, all those good places. Hep C and HIV testing. That is looking different for us. We just started HIV and Hep C testing again in August. We had to not test for a while because of the pandemic. Everybody was kind of confused of, you know, what was going on, what can we do? So we were told to stop testing, so we did that. But now we're testing again. People are happy about it, and we're happy that we can test because we give out incentives to people, and people really love the incentives. And when we give the incentives, you know, we're working with population that are unhoused, mental and health issues, a ton of different issues. So just having something to eat or a cup of coffee and, you know, all the other basic needs that we meet is a wonderful thing for people. Like, they're really excited about getting the incentives. And also by testing and getting the incentives, it makes them think about their health. So we're able to link a lot of people into care by doing the testing. And then medical assisted treatment. We have a MAT navigator now that came from the pandemic, and this person is out at each exchange and each outreach, and he can basically link people right on the spot to telehealth. Telehealth has also been another amazing tool that has came from this pandemic. If it didn't happen, we probably wouldn't have it, or, you know, maybe we would, but it wouldn't be as soon and it wouldn't be available. That has been absolutely amazing to help our folks who need assistance, who probably otherwise they wouldn't get it. You know, if we didn't have our MAT navigator and our phones and our iPads and our tablets out so that person can get help right now, we wouldn't be able to hold them, and they wouldn't get the help that they needed. You know, going to the Bridge program, going to the Trust Clinic, getting the Suboxone or Methadone, whatever they need right there, which goes into our mobile medical services. We partner with Roots Community Health Clinic and the Trust Clinic. They come to 3 of our 6 exchanges that we do, and they see people right on the site, not only for MAT treatment, they also do wound care. They take care of any health problem that a person may have or be concerned with. All right, this is a setup of how we do our harm reduction right now. So, our syringe exchanges right now, we have food truck style that we were doing in the beginning of the pandemic, which has recently changed in the last month because we're able to go outside and set up cones and tables to keep the social distancing, and also to just reconnect with our folks. It's been really hard not being able to be outside or not even being close to our participants who are used to us giving hugs and, smiling and having great conversation and, being really close to each other. It's been tough for us to do the food truck style and be out the window and not really be able to engage with our folks like we used to. And we also just 2 weeks ago started back to doing acupuncture, actually touching our clients again and letting them, feel our love and getting what they need. Our acupuncturist was only able to give out herbs and, advice and things like that in the beginning of the pandemic. But now we have stepped it up and went back to doing actual acupuncture, making sure that we're safe, wearing an N95 and a face shield and gloves. And I would recommend wearing the gowns too, but Marilyn didn't have it on that day, and that's okay. And then we have Tamir here, who's one of our community health promoters. This looks like at a Friday exchange, and I also see Jane back there too. And they are giving out supplies, and they're wearing gloves and wearing their N95 masks, and we're outside. All right. All right. So our services offered during COVID-19. All the changes during the pandemic. Food truck style exchange, social distancing, which you saw was the orange cones, acupuncture with the N95, the face mask, gloves and shields, the telehealth for mat services, hand washing stations, which you'll see in another picture. We purchased 4 mobile hand washing stations that are really super cool. And this, in the beginning of the pandemic, this was one of our, number one concerns for our folks is like, I can't wash my hands. I can't go to the bathrooms anywhere. I don't have the access to water. So we purchased 4 of these hand washing stations, and we take them to all of our exchanges, and we also take them during outreach. So that has been a real blessing for us and also to our folks. We're also working in teams of 3 or 4 people per work shift, where we used to have, 6 to 8 people working together, but because of the pandemic, we need a social distance. So we have teams of 3 or 4. The saddest thing in all this is our drop-in center. We didn't completely close, but there's no entry into the drop-in center. There's no shower for folks. There's no laundry. There's no hot food made by Daryl, who is our amazing drop-in coordinator. He would, have the whole block smelling delicious with some great goodness in the kitchen, serving everybody, which we all really miss. I miss his food. Our clients miss having a hot meal and coffee and being able to come into the building and get off the street. It was a drop-in center, a place to relax, a place to socialize, a place to come in and, depress from the world and get basic needs services. So how we do that now, and it's kind of like restaurant takeout only style, where we have a table in front of the front door. You still can get all your harm reduction supplies. You can get everything you need. We no longer give out food that we cooked. We have to give out pre-packaged meals or pre-packaged food already cooked that we get from World Kitchen. We're very thankful for that. They stop by twice a week so that we can feed people in the drop-in center and also feed people at our exchanges and sometimes even on our mobile outreach. So we're very thankful for that. Let's see, I was thinking of something that's a drop-in center, but I just forgot. That thought went out of my head. So I'm gonna move on. Yeah, totally went out of my head. All right, this is a picture of our services in Contra Costa County. This is at Bay Point, and we do syringe exchange there from every Tuesday from 6 p.m. to 8 p.m. There is one of our You can see that one right there. Here's one of our handy dandy hand washing stations that we love. And since the pandemic, what we do is we set a tent up and we cover all the 3 sides. So it's a little social distancing, and people won't be able just to walk in and, you know, be in your space. And then we have our supplies, our syringes here in the van, and a table set out. So the Contra Costa County syringe exchange is much smaller than Oakland syringe exchanges. We don't see as many people, but it's definitely starting to pick up, especially since we go to Richmond right now. We're very thankful for that. But in Oakland, we use our huge RV, and we're able to carry a lot more things because we see a lot more people. So, and there on this side is another angle. That's Alexis, who's one of our community health promoters also, and she works in Contra Costa. Still saving lives. With the rise in overdose during this pandemic, we have responded by making more fentanyl test strips and Narcan readily accessible, making sure folks can have it with them at all times. We've created Narcan keychain bags that can be carried all the time. And there's a picture of the Narcan keychain bag. That's our newest product. Before that, we made these Narcan backpacks. They were drawstring backpacks that included 2 nasal Narcan and a vial of Narcan in a syringe. And that was an absolute success because people were bringing them back to the syringe exchanges to get their products to carry in the bag, and they also had the Narcan on them. So that was a really successful, lost my thought. It was just really successful. We also give out tons of hand sanitizer. We were blessed to have many partners to get hand sanitizer and PPE to give out to our participants. Not only do we give them large bottles of hand sanitizers, we give them face masks, N95 masks. We're trying to meet everybody's need and get them what they need. And we also give out fentanyl test strips that we package here, and we put the instructions on the front. We put 1 single use in a bag, and we give folks as many as they need or as they want. Yeah, and that's it.